Hi everyone, it's Dr. G here, and as always, welcome to Discussions with Dr. G. So today we're talking about managing metabolic bone disease, which if you immediately thought there's no way that could ever be exciting, stick around because I've got stories. Metabolic bone disease, the not so glamorous villain that just loves to mess with our bones. Let's look under the hood a bit. Bone density is basically your skeleton's defense system, keeping you strong and mobile. But it starts to decline with aging, menopause, thank you, hormones, or if you're lucky enough to be taking chronic steroids. That drop in density, it means you're suddenly living in fracture country. Two of the headliners here are osteoporosis and Paget's disease of the bone. Now, osteoporosis is kind of the silent partner until someone sneezes too hard and then, poof, sudden hip fracture. It's all about low bone mass and fragile bones. Then you have Paget's, which is just kind of bizarre, really. There's this weird disorganized bone turnover, so your bones get big and misshapen. Not exactly the look you want. But let's get more physiological. Bone is like a construction site. Osteoclasts break stuff down. Osteoblasts build it up. Okay? If osteoclasts are in overdrive for too long, like with osteoporosis, you lose more bone than you actually make. That leads to fractures, chronic pain, and honestly, a whole lot of mental health fallout. Depression, anxiety, all that stuff that comes along with not being able to move the way that you used to. So real talk. I had a patient, we'll call her Grace, who was living her life, doing her thing, and then she slipped in her bathroom. Ended up with an ankle fracture. Simple, right? But for Grace, this was her first osteoporosis diagnosis, and it just set off this cascade. Walker, then a cane, then depression she swore she was too tough for. It's a reminder these diseases aren't just numbers. They actually flip patients' lives upside down. And honestly, it's not just about broken bones. We're talking about loss of independence, changes to daily life, even social isolation. Clients start missing out on things that they used to love, and that, to me, is where the disease hits the hardest. Now, what do we have in our medication toolbox? There are basically 3 camps of meds for metabolic bone disease. We have anti-resorptive agents, anabolic agents, and good old calcium and vitamin D. Starting with the anti-resorptive agents, there are a few classes: bisphosphonates, monoclonal antibodies, selective estrogen receptor modulators, or SERMs, and calcitonin. So let's start with bisphosphonates, alendronate and ristronate. All those dronates, these are our bisphosphonates. Nice little rhyme. Mechanism here is pretty nifty too. They block osteoclasts, so there's less bone resorption, or more simply put, less bone tissue being broken down, and, fingers crossed, better bone mineral density. You'll see these prescribed for postmenopausal osteoporosis, Paget's, even for folks with hypercalcemia due to malignancy. But these meds do not play around with safety. Here's where you need to pay attention. You have to take them first thing in the morning, on an empty stomach, chug them down with a full glass of water, and then this is the hardest part for some people, stay upright for 30 minutes. No, I'll just rest a sec. None of that. It is not just picky nursing. It is not just picky teaching. If your esophagus gets reminded of its job by these pills, you're in trouble. We're talking painful esophagitis, ulcers, and in rare cases, osteonecrosis of the jaw. Yeah, your dentist, your bones, and your GI tract are all on the invite list with this one. And let me just give you a quick case study because, I've had that one patient. Let's call her Kay. Took alendronate, insisted she'd be fine reclining to watch the morning news, and ended up with an esophageal burn that ruined her faith in both cable TV and nursing instructions. Please just tell your patients to stay upright for 30 minutes. It is not just us being annoying. Also, GI upset is common. Heartburn, constipation too, so you'll hear about all that. All things considered, though, we absolutely need to remember bisphosphonates are not suitable for folks who cannot sit up, have swallowing issues, or have low calcium to begin with. Next is denosumab. The fancy monoclonal antibody works by targeting rankle, which means less creation of osteoclasts and, ta-da, less bone resorption. This one's for our high-risk osteoporosis crowd, cancer patients with bone loss, steroid-related osteoporosis, and anyone who's tired of swallowing tablets and just wants to try injections instead. Just kidding. Fun fact, denosumab sometimes works better for steroid-induced osteoporosis because steroids just blitz bone cells in a way that some meds can't keep up with. Denosumab has a different action and can counter that type of breakdown. Denosumab's biggest flex is also its biggest risk. You can get severe hypocalcemia, so we always check and fix low calcium before starting. And for bonus points, there's a risk for osteonecrosis of the jaw. Seriously, it's not just folklore or dental urban legend. That's why it's critical to have your dental health checked before starting, and don't skip out on those dentist appointments while you're on it. Back pain, muscle pain, some odd infections, even high cholesterol. These are common side effects, but really it's the jaw necrosis that gets all the headlines. I'll never forget this guy, Mr. T. He showed up for his denosumab injections, looked fine, but had skipped his dental follow-up. The doc finally noticed the telltale sore, nearly missed a jaw necrosis diagnosis. For once, I was speechless, and if you know me, you know that very rarely ever happens. The takeaway here, check calcium, get the dentist in the loop, and educate. Now, not everyone's a candidate. Hypocalcemia, pregnancy, active infections, allergies, you gotta rule those out. All right, on to SERMs. SERMs, specifically raloxifene, okay? If estrogen is like the queen bee in bone health, raloxifene is her friendly imposter. It acts like estrogen in the bone to slow bone loss, but blocks estrogen in the breast and uterus. It's mostly for postmenopausal osteoporosis prevention and treatment, though it does have its quirks. SERMs bring a higher risk for blood clots. So if you have a history of VTE or stroke or transient ischemic attacks or TIAs, no SERMs for you. I usually tell patients if you get chest pain, swelling, or shortness of breath, stop the medication and call the office. Side effects can include those delightful hot flashes and leg cramps. And don't forget, stop the drugs a few days before surgery. On to calcitonin, usually in the form of salmon calcitonin. It's an osteoclast inhibitor and increases calcium excretion. Great for osteoporosis, Paget's, and acute hypercalcemia. But you'd better check for fish or salmon allergy before administering. I once had a student ask with a totally straight face, wait, does this mean I have to quiz my patient about sushi preferences? I mean, yeah, kinda. Side effects are usually mild. Nasal irritation, and if you're using the spray, maybe some dizziness or nausea. Now, we have our anabolic agents like teriparatide. You heard me. Teriparatide, the parathyroid hormone analog delivered by daily injection. It boosts osteoblasts and bone formation, but has its own big red flag. A boxed warning for osteosarcoma, so it's limited to 2 years maximum. Also, avoid it in patients with Paget's, bone malignancy history, or hypercalcemia. You might see some nausea low blood pressure, and maybe a little injection site pain. Don't forget, this one has to be kept in the fridge and tossed after 28 days. So there is some practical fridge management for your medication list. All right, let's give a little love to the unsung heroes, calcium and vitamin D. You probably already know, but let's say it anyway. Calcium is the literal skeleton of your skeleton, and vitamin D's job description is to make sure calcium gets to the bones. Both are vital for preventing or treating hypocalcemia and as adjuncts in osteoporosis therapy. Sounds simple, but there's plenty that can go wrong. You got to watch out for hypercalcemia, kidney stones, and drug interactions. You'd be amazed how many people are popping their thyroid meds or antibiotics at the same time. Obviously, this is a no-no. Teaching tip: stick with 600 milligrams of calcium or less at a time and separate them from your thyroid hormones, tetracyclines, and fluoroquinolones. Drink lots of water. Have a diet high in fiber. The works, okay? When it comes to clinical judgment, here's what I tell my students. Know your patient's bone scan history, lab values, risk factors, and contraindications before you even think about administering a med. You got to match the patient to the right drug. Check for things like esophageal issues or blood clot history, and teach. Don't forget to evaluate. Are the bones stronger? Are there fewer fractures? Are medications tolerated? Because if any of those things are not working, you may need to talk to the prescriber and change up the therapy. All right, let's talk safety, because these meds, they don't exactly come with a no side effects guarantee. Bisphosphonates, you've got nausea, heartburn, GI upset, and the ever dramatic esophagitis. Raloxifene's great until someone ends up with a blood clot. Denosumab, watch out for severe hypocalcemia and random allergic reactions. Calcitonin can make noses cranky, causing irritation or even some crusting. Super glamorous. Teriparatide, you got to watch out for bone pain and that theoretical but very real risk of osteosarcoma and kidney stones. Even calcium isn't so innocent. Too much and hello, constipation, kidney stones. What a great combo. That means our jobs as nurses is education. And let me just say it one more time for those in the back, education. Like, have you ever gone through the alendronate morning ritual with a client? Take it first thing on an empty stomach with a big old glass of water, and this part is key. Don't you dare lie down for 30 minutes. Clients always look at me like, you're making this up. But no, I'm not. It's all about preventing those nasty esophageal side effects. Here's a little one. One of my patients, we'll call him T, could not get his head around the alendronate rules. We did 3 rounds of walk me through your morning. By the next week, he'd nailed it and proudly reported 0 heartburn. Sometimes it really is those tiny victories, you know? All right, that is metabolic bone disease in a nutshell. Tricky physiology, tough meds, but with the right eyes and the right teaching, we keep our clients stronger, physically and emotionally. That's it for this episode. Thanks for joining me. There's always more quirky med wisdom to come, so I'll catch you next time on Discussions with Dr. G.